We have a great show today. We have a great meeting, great guests who are going to be teaching us all about DVT, pulmonary embolism, and most importantly, patients that are affected by it. And of course, the two keynote speakers today are going to start and end the show, and we'll introduce them when the time comes. So today's going to be, this is going to be a very exciting roundtable, partly because DVT and pulmonary embolism is something that touches the lives of all people. And it's something that's very relevant. It really doesn't matter if you're even in the field of medicine. It certainly doesn't matter if you're a surgeon or an interventionalist. It doesn't matter. It matters if you are someone who deals with patients that are getting older. It matters if you deal with patients that are at higher risk of developing DVT, which could be much younger, particularly women in many situations. And it matters if you work in hospital situations. And everyone here has that in common. So hopefully we'll have a great discussion today. You should know that the estimated risk of people developing DVT, or the incidence of that, is about 2 million Americans per year. 1 out of 10 patients that develop a DVT most likely will die of complications of DVT. So this is a very germane and active and important issue. The healthcare dollars that are spent on this are enormous. No matter what someone is admitted to the hospital, if you have a DVT, the automatic cost that goes up is about $10,000. If you happen to have a pulmonary embolism, at the very least, the cost goes up about $20,000 per patient. So the cost is exuberant. You can see the amount of people that are affected by it. So it's really critical that we address this issue and we have a good, honest conversation on the things that we have done to improve therapy and what else we need to do, because I think we have a long, long way to go. Hospitalized patients are most affected. Studies indicate that as many as 10% to 48% of patients that are admitted to the hospital could at any time develop a DVT. Of course, patients in medical surgical floors have an increased risk. That's about 10%, but patients in MICU, SICU, and all critical care settings have a markedly improved risk. And we're going to hear from our speakers a lot more about this stuff. There are 3 things that are of most importance, and you're going to hear this time and again. And the reason it's really important to understand these 3 things, which are endothelial injury, which is the inner lining of the arteries or the veins, abnormal blood flow, and hypercoagulability. These are the 3 things that if you have one, you might get away without having a DVT, but if you have 2, you likely will develop a DVT. And certainly what happens to us when we get a DVT becomes of critical importance. We all understand pulmonary embolism. A piece of clot can break and go to our lungs and cause a devastating problem, which is very life-threatening. And in some instances, patients die without even ever making it to the hospital. But there is the post-thrombotic syndrome, which we don't necessarily hear about. People get a DVT, they get varicose veins that has some clots. You get better with minimal treatment and you move on. And the reality is the post-thrombotic syndrome occurs not immediately, but 1, 2 to 5 to 10 years after the initial incidence. And it is very debilitating. It is, once again, an extreme cost to persons, individuals, to societies, as well as it's extremely debilitating. Debilitating from a standpoint of when the venous capacitance changes, when the valvular dysfunction occurs, patients have to live with debilitating conditions of leg swellings and ulcers and other things that there's really no cure for, at least no cure in sight. And as many as anywhere from 20 to about 60 to 70% of patients that develop a DVT can go on to develop post-thrombotic syndrome. So that's why this discussion today becomes really important. We have Dr. Scott Rogie, who's going to talk about this, and this is something that is very under-recognized. If you have a pulmonary embolism, really the embolism goes to the lungs, but the muscle that is the most affected is the heart, because heart has to strain a lot harder now to pump against a gradient, which is much harder. So these things have significant impact in patient survival, in patient mortality, and in a lot of other things. And we know that when DVTs occur, when pulmonary embolisms occur, if the pulmonary embolisms are small, which happen in a majority of patients, the risk of death is small. Although for a 20-year-old, 1% risk of death is still significant. But when that pulmonary embolism load becomes larger, when it becomes to a state when the pulmonary embolism can cause one to go into a shock, which is described as massive PE, or even submassive PE, when there's clinical ways to understand whether the heart and the lungs are really strained, the mortality goes up to well above 30%, which is very significant. 1 out of 3 people with pulmonary embolism would die. So this becomes really, once again, a very germane topic for discussion. And lastly, we've heard a lot about filters. There's a lot of news about filters today, a lot of lawsuits that are flying around against companies that have made filters. So I thought it would be just appropriate that we have some discussion about that.